So we'll go through what are the available options, or what are the options we have in 2024 for the management of advanced Hodgkin lymphoma. So I will not talk about the limited stage, just for the time. And I will be talking only just about the classical Hodgkin lymphoma, so nothing about the nodular lymphocyte predominant. And we'll just talk about also the new advances or the options for the management. As you know, the Hodgkin lymphoma in advanced stage is a curable disease. And the challenge was, how can you maintain the cure of a Hodgkin lymphoma, as well as minimizing the toxicities, especially the long-term toxicity. That concept came from this study when ABVD, the study was published in 1992 by George Canellos at that time, comparing the ABVD to the MOB APVD or MOB therapy. As you can see, the failure with the ABVD was about 32%, so you can cure up to 70%. However, still there is a huge unmet need for those with advanced Hodgkin lymphoma. The problem was not to cure them, is how can you also minimize the long-term side effects. As you can see with the MOB treatment, there were cancer cases secondary to the MOB chemotherapy. And since that time, the strategies, how can we intensify the treatment to maximize the cure and to minimize the toxicities. And one of the protocol to get the highest disease control was the escalated Biakob by the German group. Volker Diel and his group also at that time compared the escalated Biakob, which they added etoposide to 100 milligram daily, as well as the cyclo increased from to 1,250. The doxorubicin was given at a 35 milligram. So beside the procarbazine as well as the bleomycin. So as you would expect, you will get a more control for the disease. However, that was on the other hand, a long-term toxicities, especially the AML and MDS initially when compared to the COPP ABVD. Other strategies, and this is the 10 years follow-up, you can see the number of the cancers or secondary cancers was higher with the escalated Biakob compared to the baseline Biakob or ABVD. So other strategies to how can we also intensify the treatment and then either escalate or de-escalate, that will give us a good disease control and will minimize the toxicities. And one of these studies was the Rathel trial published by Zinzani. 2 arms, but the most important one was the PIT negative arm, those who received 2 cycles of ABVD. PIT was done, and those who had a PIT negative randomized to AVD, so omitting the bleomycin, or the standard ABVD for 4 cycles. PIT positive, 4 cycles of the escalated Biakob. The study was a non-inferiority at the beginning, and you can see there was no differences in those patients achieved a PIT negative. So AVD was comparable and non-inferior to the ABVD after 2 cycles of ABVD with the PIT negative, both into the overall survival and progression-free survival. This is the 7 years follow-up. So at 7 years, the rate of control, the disease, for those who received ABVD or AVD after a PIT negative was almost like 81%. And if you compare that to the ABVD and that study with the MOB, so increased from a 70% to 81%. So there is incremental also with minimizing the toxicity, especially from the bleomycin. The same for the overall survival. This is also for those who had a PIT negative. When they escalated to the escalated Biakob, they achieved about a 79% disease control. And this is compared to the historical data considered to be a higher, especially for those with the PIT negative. So the second one was the HD18 trial. The German protocol also, they randomized the patient to the standard of care, which is the 6 cycles of escalated Biakob or those who received 2 cycles of escalated Biacob and then randomized to 4 more cycles or 2 cycles. So the strategy here is to minimize the number of escalated Biacob after a PET negative data. And that was also a great outcome if you see the 4 cycles escalated Biacob, which is almost like a 12 weeks of treatment, 3 months. That's the half of the treatment, compared to the 6 escalated Biacob, almost comparable with the disease control. And you notice here that the disease control increased from 81 with the ABD and ABVD to 91. So this is one of the also highest disease control. But still, in those patients, the acute toxicities, either with the hematological infertility as well as the long-term toxicities with the secondary malignancies, were not eliminated because still the certain agents, especially, for example, the cyclophosphamide or toposide for the infertilities, the higher doses, as well as the procarbazine for the second malignancies. Another study also by Casanova, and that phase 3 HL started again with the 2 cycles of escalated Biacob, and then randomized after a PET negative to ABVD, so 2 cycles then ABVD. So it was not 2 cycles to 2 cycles of escalated. Now they are changing to another protocol, or if it's positive, they continued the same treatment, escalated Biacob. The results also was progression-free survival at 4 years, 86%, so increased into the progression-free survival. As you will notice, no differences will be seen into the overall survival because we have the same salvage for those patients who will progress and on treatment. However, the problem with the escalated or de-escalated, especially with the escalated Biacob, is that majority of the hematological toxicity are in the 2 first cycle. So you cannot also avoid the hematological toxicities by that strategy. Autologous stem cell transplant, this is all the study in 2002. Those who achieved the CR after ABVD, they put them into the autologous stem cell transplant versus the conventional chemotherapy to see if initial consolidation with high dose chemotherapy followed by autologous stem cell transplant will cure, and there was no differences. This is how the progress into the management of Hodgkin lymphoma over years. That's a SEER data. You can see there is overall survival improvement from 78.5 over years to 81. So almost like a 4 to 5% improvement in overall survival. That was due to the use of the PET adapted therapy, the early detection of the residual disease with the PET, also the strategies of the chemotherapy, as well as the improvement into the autologous stem cell transplant. And after that, the brentuximab, as you know, was tested initially into the relapsed refractory setting by Anas Yunus, and it showed a remarkable response for those who progressed after stem cell transplant. It was tested into the first line, into the Echelon study, where 6 cycles of brentuximab AVD compared to 6 cycles ABVD in stage 3 and 4 advanced classical Hodgkin lymphoma. The initial outcome was the modified progression-free survival. And this is the 6 years follow-up where the brentuximab plus AVD compared to ABVD showed a superiority by about 6 to 7% compared to the ABVD. And for the first time, we see overall survival benefit in a phase 3 study in advanced Hodgkin lymphoma, where the brentuximab plus AVD was superior by about 3 to 4% overall survival, absolute benefit in overall survival. This is the subgroup analysis. It was more evident in those who younger patients, less than 60, advanced stage, high IPI. And the brentuximab at that time was one of the standard of care since 2018 after the Echelon 1 study. The problem again with the brentuximab was the toxicity, especially the risk of febrile neutropenia, where the G-CSF was not mandatory at the beginning and later on it was a mandatory, so the risk of febrile neutropenia reduced from 20% to 11%. Peripheral neuropathy was the main also side effect, and 11% compared to 2% into the ABVD group, and was more also pronounced in those patients, elderly patient. One of the concerns also in a young patient is the fertility, and the brentuximab ABD, this is the data that majority of the patient into the childbearing had the same, similar to the ABVD, so it was not affecting the fertility issue. In the last year also we had the two protocols now. We have the HD21 and the SWAG, and that's the maybe the updated into the data. So HD1, you remember the escalated BIACOB protocol. Now they are testing the escalated BIACOB to something they call it BRICAD. So brentuximab, cyclo, as well as the dacarbazine, and I will show you the differences between them. But HD21 was a randomized study, phase 3, non-blind, giving a patient 2 cycles of either escalated BIACOB or 2 cycles of BRICAD, and then if a PET negative, they will proceed with 2 more cycles of BRICAD, or positive 4 cycles. So it's like a 2-by-2 design. Those who had escalated BIACOB 2 cycles, PET negative 2 cycles, escalated BIACOB positive 4 cycles. It was initially non-inferiority, so BRICAD is not inferior to the escalated BIACOB. And later on, the study design, when they at the second interim analysis, was changed to superiority. This is the differences between the escalated and the BRICAD. So bleomycin, nothing, and into the BRICAD, the etoposide from 200 to 150. Doxorubicin was increased to a 40. Cyclophosphamide, the same dose. No vincristine into the BRICAD. Brentuximab was added instead of the vincristine. Prednisone was changed to dexamethasone, and dacarbazine changed to procarbazine to dacarbazine to minimize the risk of the second cancer. This is the study design. As you can see, the BRICAD was, as mentioned, non-inferiority study. However, it showed superiority to the escalated BIACOB, and those who achieved a PET negative either received 2 cycles or 4 cycles, and no differences into the overall survival. The risk of the AML was less than 1%, almost negligible compared to the other thing. The only thing in that study was the PET negativity up to 64. If you compare that to the other studies into the escalation or de-escalation, this is considered to be lower, because PET negativity almost like 80 to 85% after 2 cycles of ABVD, or into the echelon study after the brentuximab ABD, and no good explanation for that. The same score was 1, 2, 3 negative. However, you can see that the progression-free survival, now we are achieving like a 94%. So from a 70 with the ABVD, now 94 with the 4 cycles of BRICAD, which mean like a 3 months of treatment instead of 6 months, especially in those with the PET negativity. This is just to show also the fertility was not an issue with the BRICAD, according to the study after 48 months of the follow-up. Then the SWAG study also introduced the nivolumab ABD compared to the brentuximab ABD in stage 3 and 4. It showed superiority of the nivolumab. You can see this is the baseline. There was no differences between the 2 groups. However, nivolumab into the intention to treat, because the study included from 12 years to more than 60. And when if you take the whole study, it showed that superiority to the nivolumab with about 92% compared to the 89 with the brentuximab ABD. That also was into the subgroup analysis. You can see the age group between 18 to 60, almost the close to 1, the confidence interval. But the 12 to 17 and more than 60, the effect was in favor of the nivolumab AVD compared to the brentuximab. If you do subgroup analysis, again, in patients more than 60 compared to 18 to 60 years, also those elderly patients tolerated the treatment, and that because more patients into the elderly group discontinued the brentuximab because of the toxicities with either neutropenia or peripheral neuropathy. No change into the overall survival. The only concern was about autoimmune side effects with the nivo AVD. If you see just into the lower slide here, the rate of the hypo and hypothyroidism was grade 1 and 2, so no grade 3 and 4, and about 2.7 hypo and 7% with the hyperthyroidism. The rate of discontinuation with the brentuximab was higher compared to the nivo, almost double, 22 versus 11%. This is the autoimmune phenomena. You can see majority are grade 1 and 2, so no grade 3 with the nivo. So it was a very well tolerated, honestly, protocol compared to the brentuximab AVD. The only concern at that time was a short follow-up, almost published at 12 months. Causes of death, we don't see any secondary cancer. The fertility, this is very important slide, because if you want to calculate the doses, for example, into the cardiac dysfunction with the BRCAD 4 cycles, a maximum of 160 milligram compared to 6 cycles of ABVD. If you give 6 cycles of BRCAD, the maximum will be 240, so still lower than what you would see with the ABVD. Also, the risk of fertility was cumulative doses. That's into the cyclo and etoposide, 6 cycles compared to 4 cycles, decreased from 7,500 cyclo to 5,000 and to 7,700 milligram per square meter to 1,800. Only concern is the dexamethasone in a higher doses, weight gain, as well as the osteoporosis and the immune related effect with the nivo. So if you compare, and this is just only a quick, if you see the SWAG protocol, they included the 12 years. That's something good, was not into the other studies, and elderly patient. The only excellent outcome into the terms of progression overall survival. The only concern is a short follow-up, 12 months, and they reported the 2 years now. It's because a durability of the response with the nivo, with that sustained, with that maintained, and that's the whole point. And most of the, I think, centers in North America adapted this protocol of the nivo AVD. With the HD21, they did not include an elderly patient like 60, so up to less than 60 years. They included a stage 2B, which was not into the SWAG or into the echelon. However, the question mark about the PET negativity after 2 cycles still low compared to the other. We can see with the brentuximab, for those who are PET negativity, 89%, 86 compared to 64. So it can be a good option if you want to shorten the treatment from 6 months to 3 months. It's a good for those who might have a contraindication to the anthracycline and a concern about the cumulative doses, especially into the young population. The echelon, I think that was the first approved treatment compared to the ABVD, with a longer follow-up until now, 6 years, with overall survival benefit. So the conclusion over the past decade, the treatment options for classical Hodgkin lymphoma have significantly expanded. Now we have the nivo AVD, nivo BRCAD protocol with the brentuximab, as well as the brentuximab AVD. For sure, brentuximab and checkpoint inhibitors have led to improved outcome. Further direction, which that would, I think, would help, is having a novel agents combination more into the front line, advances into the imaging, not just only the standard PET scan, as well as maybe the molecular to guide the positive residual disease escalation or de-escalation after the frontline therapy. Thank you.